Good afternoon, Mr. Chairman, members of the committee. I thank you for giving me a chance to speak today. My name is Howard J. Swidler, MD. I'm a practicing emergency physician with over 30 years experience, including 25 as the Chief of Medicine in my hospital. Chief of Emergency Medicine in my hospital. I'm also a member of the JSPAN. My pre-medical school education was in pharmacy, and as such, I have additional training in pharmaceutical chemistry, pharmacology, and toxicology. I maintain dual board certification by the American Board of Emergency Medicine and the American Board of Family Medicine. I'm here to support the compassionate use of medical marijuana bill that's currently before you. Such a bill is vital to many patients who would see considerable benefits and have few reasonable alternatives. Aside from the vast number of anecdotal reports on both the safety and efficacy of medical marijuana, there is also now a fairly large body of evidence of formal research attesting to the efficacy of medical marijuana for a number of conditions. It is shameful that we have allowed politics to interfere with the national progress of science in an area, and as a result have likely denied very beneficial treatment to many patients. Absent the legal implications, the risks associated with medical use of marijuana are astoundingly low. The current approved alternatives, if they exist at all, are often potentially dangerous, have substantial side effects, and are often addictive. As a medical doctor, it is very troubling that we have this isolated issue regarding medication, treatment, and research that has been removed from the objective scientific realm and placed in the political system. The consideration of marijuana as a, quote, narcotic or dangerous drug is irrational, and it's divorced from the reality and science. Both from the chemical structure and pharmacology are far removed from those of other narcotics, tranquilizers, and related compounds. Marijuana is non-addicting. There is no physical dependence or physical withdrawal symptom associated with its use. From a practical standpoint, it's almost non-toxic. Marijuana is safer by some measures than almost any other drug that we have. This includes prescription drugs, over-the-counter drugs, alcohol, and nicotine. In toxicology, there is something that we call the LD50. The LD50 is the dose or drug level that will kill 50% of individuals exposed to that compound. Marijuana is only one of a handful of compounds that has no defined LD50. There is also there is simply no known quantity of marijuana capable of killing a person. The other relatively important concept in pharmacology is one we call therapeutic index. This is the ratio of a drug dose that will cause a therapeutic effect to that which is toxic. We have many drugs that are routinely used where taking twice the appropriate dose can cause substantial harm. This includes narcotics as well as most of the other drugs used for pain and most of the drugs used for nausea. Even many of the benign over-the-counter drugs, and I quote benign, have marginal indexes. Taking a single dose equal to 10 to 15 times of the approved dose of acetaminophen, that's Tylenol, aspirin or ibuprofen, that's Advil, can cause serious toxicity or even death. Taking twice the dose over a prolonged period of time of any of these drugs can also have serious medical consequences. With no known toxic dose, marijuana's safety profile far exceeds even those of benign drugs. Marijuana also has no known significant drug interactions to be concerned about. All of the narcotics, tranquilizers, antidepressants, and all of the drugs used for nausea are potentially very dangerous when mixed together or when they're mixed with alcohol. In my 30 years practicing emergency medicine, I've never seen a single overdose of marijuana. Never seen a patient whose primary complaint was related to the use of marijuana, either acutely or from chronic use. Never admitted a patient for detox or rehab from marijuana. Never treated a patient who was withdrawing from or having difficulty decreasing its usage. Essentially, all the alternative drugs for appropriate conditions are addictive. Most cause not just unpleasant, but medically dangerous withdrawal symptoms. In addition, they essentially have all have substantial side effects, limiting their usage considerably. I have a couple of examples that are specific to what we're talking about that I'd like to just go over with you. Probably the two largest groups of patients that might benefit are those suffering from chronic pain syndromes and those suffering from severe nausea and vomiting associated with chemotherapy for cancer or HIV. When simple over-the-counter analgesics are inadequate, those with chronic pain now have only narcotics like morphine, codeine, and oxycodone, methadone, and the like to use. These are often supplemented with major or minor tranquilizers and or antidepressants. All of these medications are habit-forming, lose potency with extended use, and have considerable side effects. Having a non-narcotic alternative would be a real benefit. There are two options for treating nausea and vomiting that are, although I heard earlier today say we have lots of alternatives, there are really only two. One is a fairly large group of older drugs called phenothiazines. These drugs cause significant sedation. They lower resistance to seizures. They're not applicable in all patients. They cause a general, what we call dysphoria, just generally not feeling well. And they impair mental function significantly. They also have a very limited dosage range. As little as twice the standard dose of one of these drugs for nausea can be associated with severe reactions known as dystonic reactions, which cause severe involuntary and painful muscle spasms. This is a condition that I have seen regularly over my career, even for patients who come to the emergency department complaining of nausea associated with the flu and go home with one of these medications. Neither of these, we also have a newer medication, and this has been a big benefit, but unfortunately it's very expensive and it's not effective in all patients. So we have some leeway there, but it's still not for everybody. Neither of these medications are helpful really in treating the problems with appetite and wasting that are associated with some of these patients, often causing them to lose 50% of their body weight. That's not something that's unheard of. This is without a doubt very important legislation. For a select group of patients, it may literally be life-saving. For others, substantial improvements in overall quality of life may be realized. Physicians will benefit from a new addition to their pharmacopoeia, and also by being able to honestly discuss alternatives and risks and benefits. This means our patients get real information instead of information off the street. Patients will be more likely to get good information about marijuana use from their physicians, knowing they will be able to speak freely. So I urge you to move forward quickly on this bill, and I would offer to take any